Thank you, Dr. Binod and Dr. Aashita, for your valuable inputs on the topic. Next, we would like to invite Dr. Akshay Anand, sir. He would give us a brief insight about neurodegenerative disorders. Dr. Akshay Anand works as a professor at Neuroscience Research Lab, Department of Neurology, and professor in charge, Center for Mind and Body, PGI, Chandigarh. He is adjunct professor, Department of Philosophy at Punjab University, Chandigarh, and editor-in-chief of Annals of Neurosciences and Integrative Medicine Case Reports. He has 211 publications in international peer-reviewed journals, besides filing 4 patent applications. His research interest ranges from understanding neuronal cell survival mechanisms using in vitro, in vivo genetic and alternative approaches to discovering biomarkers of neurodegenerative disorders of clinical applications. His research lab is the only research lab in India to voluntarily operationalize a voluntary quality assurance regimen duly recognized by Quality Council of India. He serves as a visiting professor at Kyoto University of Medicine and Vyasa, Bengaluru. Dr. Anand was nominated for India's prestigious Padma Award and annual PGI Faculty Award 2013. He also is an advisory board member, Center for Consciousness, Harvard University, Boston, USA. We welcome you, sir, onto the dais to speak a few words about neurodegenerative disorders.
You can, whatever you like. You want her to give a brief overview. So, Dr. Aashita, can you give a brief overview on the neurodegenerative case which you're going to present after Dr. Akshay? Actually, Dr. Anand has a flight to catch. He is also having a project with IIT Chennai, so he's actually broken that meeting and come here. So he'll have to get back to that meeting. So we were trying to just, give his presentation a standalone. But yes, it is in the context of the patient or the clinical problem, I should say, which Dr. Aashita is going to present here. And Dr. Aashita will put in a few brief inputs on the clinical presentation, following which Dr. Akshay will talk about his work in neurodegenerative disorder, which will just give us a bit of a context.
Good morning, everyone. I'm Dr. Aashita Davla from the Department of General Medicine. I'm a final year postgraduate. First of all, thank you so much, sir. It's an honor to have you. I'm going to talk about an interesting case of a 58-year-old male patient who presented to us around 2 years back with the complaints of loss of memory since 8 months and slurred speech since 6 months and unable to swallow solids and liquids since 2 months and urinary incontinence since 2 months. So this patient was a sari tailor by occupation. And first what he used to design saris, but 8 months back he noticed that he was having a difficulty to hold a needle and he couldn't design the saris any longer. So that's when he first noticed his motor symptom, that was he was unable to hold a needle, and he was removed from the job. And he had this habit of going to the temple every morning, but what happened is one day his wife found temple idols in his pockets, and when questioned about it, the patient completely denied it, but the patient kept continuing the same act again and again, and he was banned from the local temples also. So he started not conversing with others. He started getting aggressive over small things, and 2 months later he developed slurred speech, and his wife noted a slurring of speech, and he started to find it difficult to recognize his family, friends. He had difficulty in naming his family members, and he also slowly he started wandering around the colony shirtless, and many times he was brought back home by his neighbors when he was found wandering shirtless on the streets. Then later they even noticed that he was not responding. There was a delay in his response to questions. So that's when they noticed that he needed a physician's consultation, and he was brought to us. And when we got his metabolic profile done, and it was normal, and his MRI brain showed chronic ischemic changes with cerebral and cerebellar atrophy, sir. His neurological examination, his MMSE was 6/30, and his lobar functions relieved mainly parietal lobar involvement with loss of visuospatial orientation and right and left disorient. He could not discriminate between right and left, and he had constructional apraxia. He had motor skills was mainly like he could not have planning. His behavior was changed. So that's when we came to the diagnosis of Alzheimer's disease, sir. But the thing that is not going in hand with Alzheimer's is that the rapid progression. Usually, Alzheimer's is a gradual, it's a insidious onset and gradual progression. But this was a diagnosis. It could be an atypical variant of Alzheimer's. So this was the case.
Thank you, Aashita, for that nice presentation. Thank you also to Rakesh and Community Institute for this invitation, because Rakesh has been a good friend for a long time. When he was doing his MD at PG, I was doing my PhD. So we used to have a lot of discussions, and I believe that he invited me to this gathering because he wanted another dimension to be brought into these case presentations we've been hearing since morning. So as a molecular biologist, I look at the disease phenotype as Aashita, she presented in a very different way. So what you look at when you look at the patients or when you read in your undergraduate and graduate degree books is how the patients present themselves, how the story unfolds, what are the features, symptoms, and how do they fit into what you read and what you see, what is the prevalence of that disease, and how you measure it, how you measure by imaging modalities that you have, MRI, CT scan. So she mentioned there was a imaging done, and she also tried to correlate that with the progression, the stage of progression and the speed of progression. But at the molecular level, you'll agree something is happening at the cellular level, right? Brains have neurons, and neurons are either dying or transmitting signals or failing to transmit. And the symptoms are that there is a loss of memory and spatial memory, as she mentioned, as clinicians watch and report that. And then you as a team fine tune the therapy that you give to them, right? But actually something needs to be investigated more in detail. And that is, what is causing the disease? And does it have a genetic origin? Does it have a molecular origin? Can we predict this disease beforehand? And can we predict not only in hospital setting, can we also predict this in the community? Wouldn't that be a good idea if we could have certain biomarkers that could help us not only predict the disease in advance, but also predict so accurately that we do not have a confusion like she presented, whether it's rapidly progressing or slowly progressing. Are there genetic markers that can predict a slowly progressing disease from a fast progressing disease? Before we go into that and tell you a little bit what we are doing in our lab, Aashita, do you not think that this could have been vascular dementia? Because so what you said is Alzheimer, which we all try to correlate with any memory loss. And in this case, you mentioned that this was abrupt sort of thing. So do you think vascular insult could lead to such memory loss?
Yes, sir. Vascular dementia usually has an abrupt onset, but this patient had no focal neurological deficits and no other risk factors such as hypertension or smoking. And on examination, we couldn't find any focal neurological deficits, so we didn't go towards the vascular dementia. And yes, there is a chance of vascular dementia. And on MRI, you have this Binswanger syndrome, where you have white matter vascular involvement. So
so you did the imaging, you did the hypertension. I read that you did the MMSE scoring also. MMSE scoring is mini mental test, which is a probe into the cognitive functioning, executive functioning, and attention and all that. But did you, for example, did an amyloid beta levels in the blood? or
Mm.
in the CSF tab?
No, sir, we couldn't perform the CSF amyloid levels as it's not done.
So this
in
is
a
a
lab.
marker of, suppose you were to do amyloid beta and your diagnosis was correct, what would you expect in a CSF tab or blood?
We would expect low A beta amyloid levels and high hyperphosphorated top proteins. That would be seen on CSF. And on MRI, we would expect atrophy of medial temporal lobe or posterior occipital region.
So amyloid beta, she argues, will fall down in CSF as well as blood because there would be more accumulation in the brain, which is the pathology. This is how the Alzheimer's disease functions, correct? Tau neurofibrillary tangles and tau pathophysiology and A beta accumulation will happen, leading to a reduction in the amyloid beta in the blood or CSF. Now, more and more reports in blood also, but mostly CSF are more in there. But this is debatable. And now this is what we also do in our labs. We are able to detect amyloid beta by getting the blood out of the patient or the CSF tab and doing it by a technique called ELISA. How many of you are familiar with ELISA? ELISA is enzyme linked immunosorbent assay. So it helps you to detect using an antibody raised against a human A beta in mice or dog or goat or whatever, and then measure what is the quantity of amyloid beta in that person who is supposed to be or is suspected to have an Alzheimer's disease versus those who are normal. So we'll have, if we have more of these 58-year-old people, patients lining up in your hospital, let's say 50 or 100, versus the same age and sex matched if possible, with a similar kind of a pathology, but not Alzheimer, let us say something else which leads to memory loss such as this, and then compare the amyloid beta levels and predict if A beta is a good marker of not only the phenotype that was presented by her, but also as a distinguishing marker between other similar pathologies, other similar phenotypes, such as Alzheimer's disease. And talking of amyloid beta, you know what we do, we try to bring in this beautiful picture, which is presented in the form of human disease, such as Alzheimer, to the mouse model, because how shall we go forward to create a therapy to intervene? So what we do is we synthesize amyloid beta in the labs, and this is now commercially available. So you can just order amyloid beta, A beta 42 and 44, and there are different forms, oligomers. And using all the consents, the animal ethical consents, using a particular kind of mouse, stereotactically inject it intrahippocampally, and that creates a beautiful model of Alzheimer's disease. And now we have an amyloid beta intrahippocampally stereotactically injected in a defined flow rate in a defined fashion in a series of or a bunch of group of mouse, which is an Alzheimer's disease mouse model. Now we have an Alzheimer's disease mouse model, and these are in the mouse cages in an animal house. And now we need to test if they are actually losing their memory, if there's a memory loss in that or not. Were you aware of that? You've heard of something like this? Something of an amyloid beta being used to create artificially an animal model of Alzheimer's disease. Why do we need it? Because obviously for ethical reasons, we cannot go ahead and use some experimental strategy to rescue the Alzheimer's disease functions or whatever memory loss functions that she presented. So we do it in the lab. We create amyloid beta induced memory loss, and we test it by using what is called a water maze. You can Google these keywords, you can just write down and you can find out what is a water maze. Morris water maze. Morris was a scientist who developed this neurobehavioral paradigm in a circular tub filled with water, and submerging a platform in artificial quadrants made out of this water tank by about 1 inch or 1 centimeter below the water meniscus. And the mouse is trained to reach this platform using spatial cues in the room. So once, twice, thrice, it'll take some time, a few minutes, to use trying not to swim, a swimming aversion technique, to not to swim and reach that platform to save itself. So if it takes, for example, 80 seconds, if it's a normal mice, and if we have put injured amyloid beta intrahippocampally, what do you expect? Will it reach there faster or slower? It will take more time because it will have trouble looking for spatial cues to reach that submerged platform in order to save itself from being drowned. So this is called escape latency time. This is used as a measure or a probe to map the memory loss. So if we use a drug such as you use, in this case, I think you use which drug? You gave
We
this
use
patient
donepezil, sir.
donepezil, and there are other drugs also. Can you name a few?
You can even give an N-methyl D-aspartate antagonist, that is memantine. We can even give rivastigmine.
So these are drugs which are basically acetylcholinesterase inhibitors in order to release the neurotransmitters into the stream so that the brain can continue to function or achieve what is called long-term potentiation. It's a molecular phenomena that results in learning and memory. So these that she used can be put in one group of mouse, one of them, let us say rivastigmine, and another group you can try to put a drug that you feel is probably going to help this patient or help the future patient, which could be, would you like to name a drug that you would like to test in your minds, whatever you've been learning? Have you heard of Brahmi? Bacopa monnieri is an Indian herb from the Indian traditional medicine. You heard of Brahmi? Bacopa monnieri. It's called Brahmi, B-R-A-H-M-I. You can Google and find what it does. There are scores of maybe about 100, more than 100 papers. And that's what we did also. We used different doses of Brahmi versus the drug that is conventionally used in the clinic and compared the rescue of function, rescue of the loss of memory, sorry, an amount of time it will take to reach the submerged platform in mice. This is how the drug development procedure processes happen in the lab. And these then emerge as drugs, which are then used as clinical phase 1 trial, on the humans, 2 trial phase, different phases of clinical trials, and then they come out as drugs. This is how the rivastigmine has come. So we need to venture forward using animal models to make this happen. Now, did you try to find out if in the family this disease was there?
No, sir. There was no family history of such similar.
Do you think it's important? The previous speaker talked about, somebody asked about the family history. Why is the family history important? One, because we want to know the cause. Is it happening? Is it being inherited? Second, to prevent it from happening or to manage it well in the family members that might inherit it. So, so there are certain gene mutations, or they're also called gene polymorphisms, which are very even smaller mutations, which may predispose an individual to Alzheimer's disease, to ALS, to Parkinson's disease, so many more diseases. So in this case, can you name a few gene polymorphisms or genes that may have been involved?
ApoE4 on
ApoE4.
chromosome 19. Presenilin 1 and presenilin 4.
ApoE, presenilin 1, presenilin 2. These are known candidates. But there are more candidates that are coming up. For example, neurotrophic factor mutations. Can you name a neurotrophic factor? BDNF. Can you name a cytokine? Dr. Rakesh, in one of the, I think the first talk, you talked about anti-inflammatories being given, anti-inflammatory drugs. So some people use inflammatory molecule polymorphisms or mutations as candidates, as possible susceptible regions in the gene that may predispose one to Alzheimer's disease or other neurodegenerative diseases as well. Apoptosis. Can apoptosis, what do you expect? An apoptosis could be useful or bad for Alzheimer? Will it be happening in Alzheimer's disease? Apoptosis is happening?
It would be happening.
Or the anti-apoptotic machinery is active or the pro-apoptotic machinery is active?
I think the apoptosis might be happening.
So one could even look at apoptotic markers if they are active or super active in Alzheimer versus other disease which is showing the same symptoms of memory loss. Now, when she mentioned some treatments, how many of you are aware of the fact that in your own clinical practice or in your future clinical practice or from the whatever you have read in the books, the drugs that you administer to a patient will have differential outcome? You think the same drug will have same outcome? All of those who believe the same drug will have a same outcome for this patient. If we had more 58-year-old patients with similar memory loss, please raise your hands, those who believe that this outcome would have been the same. The patient would have died in the same course, would have followed the same speed of progression of disease. You agree with me? You agree with me? So a drug may have different outcomes. Those outcomes could be determined by the patient's socioeconomic strata, how much educated if it's Alzheimer's disease, by the risk factors, obesity, hypertension, diabetes, could be further modified by something that I'm trying to bring to you is the genotype. You've heard of pharmacogenomics. A drug is metabolized in a certain fashion, which is a function of the genetics of that particular patient, which we miss a lot of times in our clinical practice. So, and it's very easy. Not only can we predict the disease by doing a gene mutation analysis, but we can even predict the outcome of a drug given to particular kind of patients. So if we institute a mechanism in our clinical practice where we can integrate the genetic analysis side by side, phenotypic analysis as she presented, it would be fantastic. It would help us to predict, manage, and treat the patient with more confidence, isn't it? Do you agree?
Yes, absolutely.
So even going further,
give it the other mic.
make the treatment even more person specific.
Yeah, no, take the other one because the battery will go away. Take the other one. Yeah.
To make the treatment even more, tailor make a patient treatment to a particular patient. What is, as you know, precision medicine. We can use another technology. If this patient if I were to know, if I had access to this patient, I would like to have a skin cell from this patient or a blood. And what would I do? What I would do is, what I would like to do with this patient is to take the skin fibroblasts from this patient and culture them in the culture dish, in the CO2 incubator, what we call, which simulates the human environment, and let it grow. How many of you heard of something called iPSCs? They're called induced pluripotent stem cells. For this, a Nobel Prize was given a few years back to Yamanaka. Right? You heard of that? So 4 factors that they're called the 4 transcription factors he discovered can help the cells de-differentiate. And then you can re-differentiate them to whatever cell type you wanted it to. If I had access through Dr. Rakesh or other faculty members to this particular patient, I would like to culture the skin fibroblast from this patient, de-differentiated, and then re-differentiate them into neurons. And then see the treatment that she gave, how effective it was in enhancing the cell survival or reversing the degenerating neurons versus Brahmi or any fancy molecule that you wanted to test to bring relief to this patient and to many patients in future. So if we have this investigative mindset, and if we integrate other known modalities available in research, in practice, and even in alternative forms of healthcare delivery, such as Ayurveda, yoga, Unani, Chinese tradition, they have all molecules. All these have come from plant products. We can use these iPSCs derived from this patient to test the differential outcome, which is going to be more potent, which can survive the neurons for a longer time to give more relief and maybe reverse A beta load or tau pathophysiology. This is how we can tailor the molecular techniques to engineer a better outcome for the patient in a tailor-made fashion. Because you all agreed, even though you didn't raise your hands, that same drug will not have the same outcome for all the patient, even if they are of as much, they have the tight phenotype, even if they have the same phenotype, it's not possible. So I touched on the importance of iPSCs. I talked to you about the importance and inferences and applications of genotyping, not only for prediction and progression of disease prognosis, but even for pharmacogenomics, for the metabolizing effect of genes, which is determined by the genetics. I talked to you about the animal models also. A similar kind of work we are doing in our lab, and this is basically focused on very actively collaborating with the physician friends, the neurologists, because mine is a neuroscience research lab, and getting the blood and the CSF from them from other neurodegenerative disorders as well, such as ALS, Parkinson's disease, even AMD, age-related macular degeneration, and other degenerative disease of the brain. and trying to predict and discover new biomarkers which can predict disease by using techniques that I just introduced to you, ELISA, and even more fancier techniques such as genetic polymorphism or mutation detection techniques. And then use this technology, this information to create an animal model for that disease, animal model for ALS, animal model for Parkinson's, animal model for Alzheimer, or an animal model for AMD. And then trying to use these candidate molecules or therapeutics to rescue this phenotype in the animal. And more recently, we are trying to move towards the preventive aspect of it. If we can prevent or halt the conversion of a pre-disease, in this case, Alzheimer's pre-disease would be, if you were to catch this disease early in this 58-year-old man, what would you call it? If it was Alzheimer for sure, what is pre-disease, pre-Alzheimer called?
Mild cognitive.
MCI, mild cognitive impairment. If it has a vascular origin, if it is vascular dementia, when we were trying to talk, you must be listening, what would you call it? There's a term for what is pre-vascular dementia, pre-vascular insult, or pre-stroke. Anyone? TIA, transient ischemic stroke. What is a pre for diabetes? Pre-diabetes. What is a pre for wet AMD? Dry AMD. What is the pre for cancer? So pre-cancer. If we can recruit these individuals at the community level in collaboration with our community people. Dr. Maruthi is here, is the head of your community medicine department, and more such faculty and faculty members in other community medicine departments around the country. We can get them at the pre-disease, in this case, pre-Alzheimer is MCI. Then what can we do? We can do far more. We can give interventions such as lifestyle modification, risk reduction techniques, which could be anxiety stress reduction, which could be exercise, it could be yoga. We can devise and propose yoga models and investigate the outcomes at the molecular level of all the markers that I just mentioned, namely
ApoE4,
okay,
SNL1,
then
SNL2.
So ApoE before pre-disease, post-disease, pre-disease and follow-up, and then looking at the expression of this marker genetic level at the molecular level also. What else?
A Presnelin1 and a Presnelin2.
Most of the genetic markers may not change, but there are theories, and we must investigate if even the epigenetic changes, which are not really core genetic, but sort of epigenetic, may reduce or alter the changes, the genetic changes also.
And the
BDNF I mentioned, BDNF, tau, A beta, what else?
And yeah, A beta amyloid CSF levels, and yeah,
by giving
hyperphosphorylated tau
correct.
proteins.
Because obviously for pre-disease, we cannot give them donazepam, right? But can we prevent this mass epidemic? Now, is there a link between a communicable disease and a degenerative disease? Finally, on this, then I will end.
I think so, sir, because there's a good correlation of neurodegenerative disorders with low socioeconomic status or low education, actually. And it has even been shown that if the patient with lower IQ has more risk of developing a neurodegenerative disorder.
So the risks involved in lifestyle disorders, which include neurodegenerative disorders, make you vulnerable to communicable diseases such as COVID-19. We all know that. There is a direct link. What better situation, a calamity or a pandemic than COVID, which has unmasked the link between a neurodegenerative or a lifestyle disease and the communicable disease such as COVID-19. So it is even more important for us to work at the community level, at the molecular level, in an integrated fashion to make use of this COVID-19, what information it has unmasked, of the vital link between lifestyle disorders and our susceptibility, our immunity, and the way we conduct ourselves, the way we not only conduct our lifestyle habits, but also the way we conduct our medical education and research and practice. Thank you very much. I'll be happy to take questions.
Thanks a lot for this, Akshay. And yeah, so would anybody like to give their inputs? Aashita, we prepared some students, who studied your case for the problem, and I'm just forgetting who they were. Yeah, okay. So Sanjana, is it? Yeah, Sanjana. So Sanjana, please, yeah.
Good morning, sir. Thank you for this opportunity. Sir, since you have mentioned the use of other methods such as yoga and Ayurveda to treat or prevent Alzheimer's, I would like to know your input or your views on the use of aromatherapy.
On
Aromatherapy, sir. Use of essential oils or aromatherapy on the cognitive effects of Alzheimer's. Do you think there would be any sort of improvement in the cognitive effects?
of the oil massage, and so thank you for that question. In general, what I was trying to say was we should move forward in more and more research into areas that we haven't really unearthed till now, or very little is known, and this is one of them. Of how much aromatherapy or massage therapy may help in alleviating cognitive impairment or pre-Alzheimer, which is MCI, will be based on an argument that it will bring relief and stress. To that extent, yes. But to the extent if we can unearth the molecular mechanism behind it or the mechanistic pathway behind it, more research needs to be done. And it is not my area of research, especially this part of massage therapy and myofascial massage and cognitive impairment. But from